So namaste everyone. I am Dr. Ankur. I am professor in oral medicine and radiology at NPDCH SPU. The topic for today's lecture is object localization technique. Now here we start with the lecture. So in radiology we commonly perform IOPA. IOPA is the intraoral periapical radiograph that exposes a three-dimensional object and gives us a two-dimensional image. So the third dimension or the depth of the object is always obscured or superimposed. So that creates trouble whenever we try to operate or surgically extract a tooth or the object or a foreign material or a fractured tooth if we want to oppose it. So the third dimension is important. So in order to reveal the obscured third dimension, this technique is used. So indications of performing this technique is to localize a foreign body in the jaw or the body, some impacted or unerupted tooth if they are not completely erupted or unerupted or impacted inside the jaw, so where they are present to pinpoint them. Supernumerary tooth, broken needle or a foreign object or a foreign body in the jaw or the tissue, some retained roots, fractures, soft tissue calcifications, some intraosseous tumors, salivary gland stones, and some filling material. When we perform some restoration, the object or the material sometimes get impinged, and to localize them where exactly they are, we can perform these techniques. So we'll start with the techniques. There are two techniques actually. Basically there are two techniques. First is the Miller's technique, second is the Clark's rule or Clark's technique. So Miller's technique stands, it tells that two images are to be taken at right angle or perpendicular to each other. So perpendicular means at right angle. So first image that we take is an IOPA, suppose. So IOPA gives us two dimensions, superior inferior and mediodistal. So mediodistal and superior inferior dimensions are there, but the depth of the bucco-palatal or buccolingual depth is always missing. So in order to get that, we have to perform a second view perpendicular to IOPA. So in case of IOPA, we can also take some OPG. So OPG also gives the same dimension as IOPA, but the perpendicular to these two will be an occlusal, cross-sectional occlusal. So cross-sectional occlusal will give us the anteroposterior and the bucco-palatal or buccolingual aspect. So this gives us the exact pinpoint three dimensions of the object so as to extract it. Then is the tube shift or Clark's technique. So Clark's technique is not shifting the tube perpendicular but to some angle. So we'll discuss it when that topic will come. So we'll start with the Miller's technique or the right angle technique. So Miller's technique, two images, two different views. One I said OPG or IOP, and another one can be occlusal. Or in case of extraoral, one can be a PA view, one can be a lateral view. So perpendicular, two perpendicular views are taken. So this is first example when there is an impacted canine in the maxilla. It is in the second quadrant. So the first image on the left shows an IOPA, the normal IOPA with the arrow pointing towards the impacted canine tooth. So we know that the impacted canine tooth is at the middle to apical third of the deciduous tooth, but where it is present palatally or buccally, that we don't know. So in order to extract that tooth, we need to know the direction or the part of the jaw from which we should perform the surgery. So we have taken a cross-sectional view, cross-section of the maxilla, the occlusal view in which it is shown to be present toward the palatal side of the jaw. So here we are getting the three dimensions, two dimensions in IOP and the third dimension in the occlusal. Second example shows a broken dental instrument or a burr which somehow got impinged into the jaw. So this is the lower jaw, the mandible and the fourth quadrant. First image is of an IOP commonly performed by any dentist. So here the object is shown close to the superior cortex, somewhat close to the third molar which is absent, but close to the superior cortex. We don't know whether this object is close to the lingual aspect or the buccal aspect. So we performed a lateral occlusal or a cross-sectional occlusal, and the object is very much close to the lingual cortex. So in order to retrieve this, the approach should be from the lingual aspect. So here we are seeing the advantage of performing the right angle technique. Third example is of dental restoration, which somehow got impinged into the tissue. So here is a case of fourth quadrant. 4/6 is extracted. Periapical to that, we can see some opacity. Now in the IOP, it is always difficult to find the depth of the lesion of the object. So cross-sectional occlusal or the lateral occlusal shows that the object or the filling material is present immediate, just periapical to the 4/6 or exactly in the same location of the 4/6. So we need not to worry about the cortices, although it is close to the buccal cortex but not the lingual one. But it is appreciated that it is present periapical to the 4/6 and quite below it only. Fourth example shows there is a tooth root or tooth getting displaced into the sinus, the left maxillary sinus. It is a case of tooth which was present in the second quadrant of the jaw. First is a PNS view, perennial sinus view. It is a common complication. So if there is a palatal root of 2/6 or 1/6, and if we try to extract the tooth, the root got fractured. Now if we try to remove the tooth, the root can get slipped or displaced into the antrum. So this is what is the case. Some tooth-like object, or the tooth or the root is placed inside the antrum. So the penis gives the two dimensions, the superior inferior and the mesiolateral. So in this, we don't know how posterior or anterior is the tooth root. So lateral ceph was taken. So in the lateral ceph, the object or the tooth root is seen to be lying a bit posteriorly or close to the posterior wall of the sinus. So it is not anterior, it is a bit posterior. So it is easy now to retrieve the tooth root. Fifth example is a case of an intraosseous tumor. So intraosseous tumor of mandible. So a tumor should be dissected. So for dissecting a tumor, if the tumor is only associated with the buccal cortex or the lingual cortex, just like an osteoma or a tori, or there is a general involvement or both the cortices are involved or the entire jaw is involved. So first is an OPG, a cropped view of OPG showing one impacted tooth, and pericorneal to that is a cotton wool appearance, somewhat like cotton wool appearance, dense opacity, surrounded by one thin or translucent capsule-like appearance. So it's an intraosseous tumor. Well, I'm not going to tell the name because the topic is not about the name of the pathology. It is about the technique we will be following to extract or to resect the tooth or the tumor. So in OPG, the pericorneal radiopacity which is present, this completely obscures the depth of the pathology, whether it is close to the buccal cortex or buccal side or the lingual side, or it is present in both the cortices or throughout the width of the jaw. So one lateral occlusal was taken, and seems that the pathology is appearing the entire segment of the jaw. So both the cortices are involved completely, and this is not a pathology of either side. Sixth example, this is a case of a fracture of mandibular body. So mandible or maxilla or zygomatic arch or any part of the jaw or the skull, if it gets fractured, surgeon wants to know whether it is a favorable fracture or an unfavorable fracture. Or so favorable fracture is one in which the broken segments or fractured segments are opposed to each other; they're not separated. So it is easy to treat those cases. So the first one is an oblique view, the lateral oblique of the body, which shows a fractured line, which is depicted or marked by the arrow. So in this image, it appears to be a favorable fracture. It is not displaced. But if we want to see exactly whether it is displaced buccally or lingually, so we have taken a cross-sectional view also. In the cross-sectional view, things look a bit complicated. There is a clear-cut sign of jaw displacement, so it is a case of unfavorable fracture. How one view of or one radiograph shows it is a favorable fracture, whereas the other one shows it is an unfavorable fracture. So all the three dimensions are important whenever we want to make a judgment of which technique we want to perform to treat a case. Second technique is a Clark's rule or tube shift technique or Clark's technique. Tube shift is not exactly the right angle that we did earlier with the Miller's technique. So in this, two IOPA, or we can say two occlusal, or any of the two radiographs, but commonly performed with IOPAs only. So two IOPAs are taken, one with the normal orientation and one with a slightly changed tube position or angulation. With this change in angulation, the apparent position of the object also changes. So the principle of this says the relative position of the images of two separate objects changes when the projection angle at which images were made is changed. So this is a principle in graphically the principle can be explained as there are two objects. So object A and object B, and there is a tooth. This is the film which is always placed palatally or lingually. This is the BID or PID. This is the mesial aspect and this is the distal aspect. So if we take a periapical view with normal orientation, both A and B will superimpose on the tooth. But we don't know whether the A is lingual to the tooth or B is lingual to the tooth when it comes to the IOPA. So by looking at the image we can't say, but here we know, but here we can't say. So we perform a tube shift technique. Tube is now shifted towards the distal aspect, still imaging the same objects. So by distally shifting the tube, we get an image where the B, the A object and the B object, they have shifted in two different directions. The A has shifted in the direction of the tube movement and B in the opposite object. Yet we can't say whether A is lingual or B is lingual, but yes, they both have shifted in the opposite directions. So in order to understand whether an object that has shifted is buccally or lingually, there is an acronym called as SLOB. So SLOB means same lingual, opposite buccal. So if the object is shifted or is shifting in the direction of the tube, the same direction, it is the object in the lingual aspect, or lingual to the reference object or the tooth. So if it shifts, so if the object is in buccal plane, it will always shift against the direction of the tube, so opposite to the direction of the tube. So taking that into consideration, the first image, the top one, in which the black object is lingual to the second premolar, one common IOP we have taken in the routine or the normal orientation, the object is appearing very much periapical, exactly periapical to the second premolar. Now, if we shift the X-ray tube more anteriorly and then take or performing the slope technique or the glass technique, the object is also appearing to have been shifted mesially. So we shifted the tube mesially and the object also shifts mesially. So it is slope, same lingual. So it means when the object is moving in the direction of the tube shift, then it is the object present in the lingual aspect. So it is in the lingual aspect. Second situation, in which the object was placed earlier in the buccal, when it was placed in the lingual aspect, it is now placed in the buccal aspect. Same IOP is performed, still it is present periapical to the tooth. Now we again shifted the tube mesially. Now the image of that opacity or the object has shifted a bit distally. So if it is a bit distally, as we know, it is opposite buccal. So it was present buccally. This we can infer from the image. This is the normal, and this is when after shifting the tube mesially, the object has moved distally. So in earlier cases, it was the normal one. Then with shifting the tube mesially, the object also moved mesially. So it was same lingual. And in this case, this one is opposite buccal, so slope. Now there is a third possibility also, the possibility that after performing the slope, the object will still be in the same position as earlier. So this case occurs when the object is present in line with the reference tooth reference. For example, if we perform a slope here, and the object will always, like in the second image also, it will be periapical. So it is in the same line or exactly periapical to the tooth. So it is not buccally or lingually, it is in line with the tooth or just periapical to the tooth. So it will not shift anywhere. Buccally or lingually, it is not shifting. It is not going to shift anywhere, either anterior or posterior. So in that case, it's the third scenario where the object will not shift, but if it is shifting, we have to use the slope acronym. So that's it for the lecture today, and the references that I have used.